Welcome, everyone. So glad you've joined us today. I'm Hamie Tawarson. I'm the Executive Director here at the National Academy for State Health Policy, otherwise known as NASHP. NASHP is, for those of you who are not familiar with us, we are a nonprofit, nonpartisan organization that has worked with state leaders across the country for over 35 years. And our mission is really to advance innovative health policy strategies with states to improve the health of their state residents. So today we are going to focus on taking on the cost of prescription drugs. Research has identified that an estimated 40% of people across the country have difficulty affording their prescription drugs, and 1 in 5 people take on debt or declare bankruptcy due to drug costs. NASHP has been focusing on this topic with state leaders for quite a while. In 2017, state leaders came to us here at NASHP and asked us to convene them and support their efforts to think through how to make prescription drugs more affordable for consumers. In response, we established a Center for Drug Pricing, and through that center, we work with a number of different state leaders, red, blue, purple, across the country, on different strategies to really think about how to address this challenge. Today, we're going to talk about one of those strategies that's really emerging, prescription drug affordability boards, otherwise known as PDABs. PDABs are independent entities that review high-cost medications and in some states have the authority to set upper payment limits on reimbursement. PDABs are an emerging strategy. To date, 7 states have established PDABs in an effort to make vital medications more accessible and affordable for their state residents. And this state legislation was not just state leaders advancing it, it was often supported by consumer and other groups across the states. NASHP's work on PDABs has been had different variations. We have worked with a number of states individually in their development of PDAB since 2017. We've also tracked PDAB legislation, and we've seen proposals considered across red, blue, and purple states. Today, we're really excited to host this discussion and hope that you learn more about what states are doing with their PDABs, their lessons learned, their lessons that they're learning, and future opportunities as they really think about how to help consumers access more affordable prescription drugs. Before we dive in, there's just a few programming notes. There's going to be time for audience Q&A following the expert panel. So please feel free to share your questions throughout the discussion using the Zoom Q&A feature. We're going to do our best to get to as many questions as we can today. We only have an hour, so we'll do our best. And a recording of today's discussion will be shared with you in a follow-up email along with the resources referenced during today's discussion. With that, I would like to introduce our expert panel. Great to see you all here and welcome. I'm here in DC, but we have experts from across the country here on this Zoom today. First, I'm going to introduce Lila Cummings. She is the Deputy Commissioner of Health Policy for Colorado's Division of Insurance and is the Acting Director of Colorado's Prescription Drug Affordability Board. Next is Tony Laurie. He is the Chair of the Minnesota Prescription Drug Affordability Board. Third is Ben Rome. He is Dr. Ben Rome. He's an assistant professor of medicine at Harvard Medical School and faculty at the program on regulation, therapeutics, and the law, or portal, where he has done extensive work helping states implement prescription drug affordability boards. And last but certainly not least is Andrew York, who is the executive director of the Maryland Prescription Drug Affordability Board. Good to see all of you, and thank you for joining us today. I'm actually really excited for this discussion. I know you all have so much to share, and I hope you all in the audience really learn some new things about PDABs and how these states are approaching their work. So I think we can start with perhaps a Q&A and just have you each respond to some questions. So I am going to start with Andrew. Andrew, specifically, of course, everything varies by state, but generally, can you share how PDABs work, their primary goals, and then where is Maryland on this journey?
Yeah, thanks, Amy. So again, thank you to Nashby for this opportunity. I'm very excited to talk on the subject. So I feel like I can answer this question because we were the first prescription drug affordability board. Maryland was created in 2019, though obviously, as Amy mentioned, there's been a lot of additional boards added. So I would say at the highest level, the prescription drug affordability boards are basically a tool that states can use to make prescription drugs more affordable for patients. And all of them, I would say, follow the same general structure. They seem to be based on similar legislation, but there are certainly differences between each state. So I'm happy to go into that if that's helpful. But I'll kind of say it at a high level right now. First, they generally have the board, which is kind of the policy making body. And they're often made up of unbiased experts in the space. Each board has a maybe slightly different structure. Ours in Maryland is a 5-person board. And our chair is a longtime public servant. He was a legislator and then a health secretary in Maryland. We have 3 health sciences researchers and then also a physician. So I think that's representative of the types of boards that you would see. They're generally also supported by a stakeholder group. Ours is called our Stakeholder Council. And that basically has representatives throughout the supply chain that can kind of weigh in and provide the perspectives and provide thoughts and feedback from the perspective of different stakeholder groups. Ours is a 26-member stakeholder council. I won't go through all the different members there. And then again, the primary goal is generally to protect or make prescription drugs more affordable for patients and the healthcare system. I like to point to the purpose in our legislation. I'm not sure if all entities have the same purpose, but it basically just goes through all the different folks that this board is trying to protect from the high cost of prescription drugs. And there's generally 3 tools that these boards have to try to make prescription drugs more affordable. One is a cost review, or I think in Colorado, it's called an affordability review. And this is basically a tool for the boards to kind of look under the hood and understand if and how prescription drugs are causing affordability challenges for different folks within the state. The biggest issue that we have, folks on the line may be familiar with this, is just that it's a very opaque system. And what we see is often not like we see a gross spend that is often unrelated to the net spend of the drugs. And we often need more information to understand, what is the actual cost to the patients, and are patients having trouble affording and accessing those drugs, as well as other folks within the supply chain. And we do that through our cost review. So it is a tool where we can gather more information and do a deep dive on specific drugs to understand if they're unaffordable or not. The next thing is upper payment limits. So this is a specific policy that often exists with certain boards, though not all boards have this authority. And I would say this is a novel policy that the boards are kind of working through how you implement this tool. But ultimately, it's a tool to make prescription drugs more affordable. And again, each state is a little bit different. In Maryland, for example, it's for state and local government. I think other states can apply this upper payment limit at the full state level. But it is a tool that is often available to these boards. And then finally, they can just make general policy recommendations. So again, you have a bunch of subject matter experts that all they do is, live and breathe prescription drug access and affordability. So they can also just be a policy body for legislators, other partners within the state. And in Maryland in particular, we've said that, our upper payment limit is a tool in the toolbox. But I think we're looking at everything that's available to the state to make prescription drugs more affordable. Just in terms of where Maryland is as a whole, we're actually at that first step that I had mentioned, the cost reviews. So our board selected 6 drugs for the cost review study process. And then, so we're working through that process now. We've just announced them in May. Staff is currently working through the analysis based on different data sources, but then we're also going to put out a request for information to gather additional information from stakeholders. And then ultimately the board is going to make a decision on if a drug has led or will lead to affordability challenges for high out-of-pocket costs for patients or the healthcare system. So that's the determination that they make. We're also working on something called our upper payment limit action plan. So in Maryland, to enact our upper payment limits, we need to draft an action plan that basically says how they're going to work. That's something that we're actively working through. Once the board approves that, it goes before something called the Legislative Policy Committee in our General Assembly. And then ultimately we can start setting up our payment limits based on that. And then also we have an annual report that we do that allows us to basically summarize the work that we've done, but also make policy recommendations such as legislative recommendations and things like that. So these are all kind of active projects that we're working on in Maryland right now.
Thank you for that, Andy. Very helpful to hear what's happening more broadly on PDABs and what's happening in Maryland. So I want to give a chance for Tony and Lila to share what's happening in their states. So Tony, I might turn to you next. Can you share just a brief overview? Minnesota is a recent state that enacted legislation to establish a PDAB. So can you share where you are on those efforts and how you think this can impact patients?
Sure. Yeah, you started with the first PDAB, Andrew, there, and we're the baby in the group here. Just starting to stand ours up, going through some growing pains. Let me start, too, by saying thank you, Hammy and Nashby, for fostering this. I'm a longtime policymaker myself and have engaged with Nashby on many different topics and really appreciate your work and your ability to help share the experiences among states. I mean, and this PDAB is a great example because the states are the laboratory of invention. You know, I mean, we're all faced with constituents and people, neighbors, friends, loved ones that are struggling with the high cost of prescription drugs. You mentioned, Tammy, that 40% struggle with prices. Half of those, you know, take on debt or declare bankruptcy over those costs. 30%, you know, two or three quarters of those that struggle actually ration their drugs in ways that are not, you know, make the drugs less effective. I mean, no drug is effective if you can't afford it and you can't take it according to prescription. And that's sort of how we got started on this, was through consumers and their struggles with, you know, a couple of the well-known, the insulin, inhalers, EpiPens, things like that, coming to the legislature, coming to policymakers, coming to the Attorney General, several different ways and different approaches, some real progress on those, but through that understanding that this is a much bigger issue than just individual drugs that become the issue du jour, if you will, that comes before the legislature, and we need a more robust process. A few years ago, our Attorney General assembled a task force to try to come up with ways to approach prescription drug affordability. The PDAB was the #1 recommendation, and the legislature and the governor saw fit to establish our PDAB. But I always, similar to Andy, I try to couch it in the fact that, you know, it's one aspect of a much broader transparency set of statutes. In fact, in Minnesota just yesterday, our Minnesota Department of Health released their first list of drugs of substantial public interest. And I think they focused on the 10 most egregious drug families that where the prices paid were significantly in excess of the manufacturer's list price. What's going on here? You know, and so this is just the list of those drugs as of today. And the Department of Health and our Health Economics Department is going to dive in and look at where in the supply chain are these prices getting added to give, and they're going to share that with our board and help us understand that as well. So again, we're just now standing it up. You know, we'd probably have our executive director, like Andy, if we had one. We don't yet. So I'm pinch hitting as the chair of the board. But again, couched in this transparency thing, I think is really important because you can't fix a problem you don't understand, and you don't have the data to really unpack it. And the pharmaceutical supply chain is so complex and convoluted, and so much of the data is not at all public that, you know, really looking at these drugs of substantial public interest, other avenues for looking at it as well. But the Minnesota law requires everyone in the supply chain to submit data now that this drug is on the list to MDH, and they're going to help us unpack what's happening in the supply chain before it gets to consumers. The other piece that you were asking is how is this going to affect consumers? And it's tough to answer that question with specificity right now. I mean, we're just starting the questions. That's a really core but important question. What does affordability mean? Are we trying to address out-of-pocket costs that consumers experience? That's sort of, we have to stay focused on and grounded in the effect of consumers at that very granular level. But there's also all of the costs that the system bears. And there are all kinds of tools to protect consumers from exorbitant out-of-pocket costs, a high area of attention, but might not address the system costs. And so we have to have some really more detailed conversations about exactly how we're trying to approach this and make sure that we understand we're doing it in a strategic manner. Getting some of this material from MDH and a really data-driven approach where we're intentionally making sure that we invite all of the players in the supply chain to come and give us their perspective too. We don't want it to be completely one-sided. Maybe a long answer to a short question, but we're just starting to stand up. Really anxious to be joining this space and doing some of our own invention. We have a long history in Minnesota of some very robust data gathering efforts. And so these drugs of substantial public interest that I mentioned, we're going to try to hook those up. We were one of the first all-payer claims databases and one of the more robust versions of that. And we're going to try to combine this data too so that we can kind of see, okay, so this drug, it has a list price of this, but then through rebates and all kinds of different pricing mechanisms through the supply chain, it changed and the price paid was this. How often is this used? In what context is it used? The all-payer claims database can unlock a great deal of that information for us as well. So a really data-driven exercise, trying to be collaborative with all of the players in the market space and staying grounded in the fact that we're trying to drive improvements in our healthcare system to help people.
Great. Thank you, Tony. And you're just beginning the journey, so appreciate you sharing where you are and where you're going. Lila.
Yeah, happy to speak to Colorado. And I'd say if Maryland's the oldest child, Minnesota's the youngest child, we're happy to be one of those middle children in here. And I promise, I don't think we have a middle child syndrome issue though. So Colorado's Prescription Drug Affordability Board was established in 2021. So the board has been operating for coming up on 3 years now. And I want to, focusing on how Colorado and its board has gathered diverse perspectives, I think it's important to highlight the diverse perspectives that are already on the board, as well as our advisory council. And then I'll a little bit more about the process that the board has taken, both in establishing how their program would run and then actually running the program. So one of the things that I just, with our board, it's required that the board have either, a higher education degree in clinical medicine or health economics. And we're fortunate in Colorado to have 5 board members with expertise as clinicians and as hospital administrators. And so we have our board chair is a physician for over 20 federally qualified health centers on the western side of our state, which is one of the more rural parts of our state. And she travels across 20 clinics seeing patients every week. Then we have a representative from the largest safety net hospital, the only safety net hospital in the state, on our board. And so he also gets to see, and hear from patients daily about what their issues are and what their struggles are. We have an oncologist on our board who, again, is a practicing physician seeing patients daily. And so he's got that perspective of folks, going through a pretty terrible diagnosis and then having to deal with issues with affording their medication. We also have a hospital administrator for one of our Eastern Plains hospitals, a critical access hospital, where we know rural communities face different challenges in accessing prescription drugs and affordable medications. And then last but not least, we have an administrator from the largest academic health system in the state. And so she has just an incredible breadth of expertise and knowledge about the different challenges that folks face, both in urban and more suburban areas. So the board itself, really, we feel very fortunate. They were chosen and they just have incredible access to the patient stories, and just a long history of work and working in these fields where they've heard from patients, heard from families. So that's, I think, one of our biggest strengths in the Colorado board for gathering those diverse perspectives. We also have a 15-person advisory council, and I like to say that the representation on this council really covers the care continuum. So you've got everybody from patient representatives, we have 4 patient representatives, all the way up through kind of prescribers and providers. So really, as you're kind of thinking about this from that access and that clinical perspective, they help us gather diverse perspectives as well. We also have folks on the advisory council that really represent the entire supply chain. So everybody from the manufacturer to the wholesaler to the pharmacy benefit management firm to the insurance carriers and providers as well. We've got their perspectives, and they bring a great depth of knowledge to the work of the Colorado board. And then I'd say, in terms of the actual the actions to gather more perspectives, because I would say our board has indicated time and time again that while they do have incredible experience, they do want to hear more from patients, particularly as you go down from this general idea of prescription drugs being unaffordable to picking a specific drug, right? Like when you pick a specific drug, there's a very unique set of stakeholders that you need to engage to get that information. So as the board was setting up their program, they took considerably longer in the rulemaking process, state regulatory nerd language there, but then they needed to. So they could have, very quickly run through some rules, established how they were going to do affordability reviews, and established upper payment limits. But instead, they took a year and a half to do that. They took a year and a half with many rulemaking hearings, as well as night and evening and daytime stakeholder meetings and multiple rounds of drafts of setting up their program to hear from both the advisory council and from other experts across the state and the nation. So I think they worked to really try and set up the program with those diverse stakeholder input in mind. And then as they're running the program, they really have paid attention to making sure they're getting as much information from folks as possible. And so while the statute really only requires the board to accept information from patients and caregivers, physicians, and manufacturers, they've sought information from more. And they've also asked us as staff that we're, kind of boots on the ground gathering that info to create as many opportunities as possible to gather that information. So while there is always the opportunity to provide written or public comment, we hold meetings in the weekend or on the weekend and in the evenings. We have created, opportunities for small group meetings. We responded to a request for surveys for patients that might not feel comfortable or might not know how to engage in kind of state regulatory processes. So created surveys. And then we've also worked to outreach to some of those disease or condition specific consumer advocacy groups and work with them. And we were able, in one example, to work with one of the groups. They had a flyer encouraging patients that kind of sign up for their newsletter to participate in the survey. And we worked to make sure that what was in their flyer was accurate so that we could get the word out to as many people as possible. And that resulted in, that collaboration resulted in nearly 250 people filling out a survey in a very short amount of time. So really just working with and being open to talking to consumer groups, and then really being open to talking to anybody along the care continuum or supply chain.
Great. Thank you for sharing that, Lila. And just a reminder to the audience, if you have questions, just please put them in the Q&A so that we are going to have a specific time where we're going to follow on all those questions. Okay, Ben, I had a question for you. So you have been sort of working on this topic for a number of years and working with several states. Would really appreciate your perspective. High prescription drug prices have been challenging consumers and employers and others for a long time. Why PDABs now? And what is their long-term viability in your opinion?
Sure. Thanks, Amy, and thanks to NASHB for putting this together and for involving me and others on the portal team in the work to sort of help PDABs in this sort of new adventure. I totally agree with what you just said, which is that drug prices have been a concern for a long time in the United States. But I do think that the problem has gotten worse in recent years. And just one example of that, a new drug that was coming out on the market in 2008 cost an average of $2,000 a year. Now, a new drug that comes out on the market in the US costs over $150,000 a year on average. And so we're just in a little bit of a different world in terms of thinking about prices of prescription drugs today than we were a few decades ago. I'm a primary care doctor. Almost every week, my patients sort of come to me and raise concerns about costs of their medicines and access and affordability of their medicine. So this is a really important issue and kind of public health problem. There's, in fact, broad support for governments to sort of step in and do something about the cost of prescription drugs in response to sort of what patients are experiencing. People have just their own experiences or their families' experiences that drive them to support this issue. But despite that broad support, what we've seen is very limited federal action on prescription drugs. And in fact, even the most recent action, the Inflation Reduction Act, which is arguably the most sweeping set of prescription drug pricing reforms in the past couple of decades, those changes were limited to the Medicare program, which is a federal program, and they're not going to directly affect the patient populations who have private insurance, which is about half the US population, or Medicaid, which is partially funded by the states. So I think that's the sort of context in which we've seen a lot of states, sort of that sort of lack of federal action to sort of step in, take the lead on this issue. And as we've already heard from the other three panelists, there's a lot of variations in the approaches states can take in doing that. But the PDAB approach, one thing that's been sort of really kind of inspiring to see about sort of the way legislators have put this together is recognizing this is a complex topic. The states are convening an independent board of experts who can sort of carefully consider the best ways to move forward, right? The best ways to take actions that are actually going to make prescription drugs more affordable in the state. So what we've seen over the past few years, sort of, as states have started to do this, is very thoughtful discussions by the boards, very, purposeful decisions about how to proceed given the complexity of the topic. And so, I think that, sort of going forward, as long as high prices remain a barrier to patient access for their necessary prescription drugs, this is going to be a major source of public concern. That's going to sort of lead to more and more states wanting to engage in this space over time. And I think we've seen PDABs become a major way, sort of an important way states are starting to do that.
Thank you for sharing that, Ben. And we're getting a couple questions in the chat, so I might pick on some of those to share with all of you. So one question that we have is, so we've talked a little about how, PDABs play a broader role than folks might think in terms of thinking about the cost of prescription drugs. There's a specific question about the role of the PBM in controlling drug prices and how PDABs may address that piece of the drug supply chain. And I don't know, Andrew, would you want to take that one?
Sure. Yeah, thanks for the question. Yeah, so I think one of the things that all the boards that exist have taken into account is the fact that this is an extremely complicated space. And the entire supply chain is extremely complicated. There's a number of very important stakeholders throughout, and all of them have their own incentives and play their own role in the ultimate price and cost of prescription drugs, as well as what the patient is paying out of pocket. So, obviously the role of pharmacy benefit managers has been a major issue federally and then also within states. And I would just say, in terms of how the PDABs are managing it, or the prescription drug affordability boards, I would just say that everything is on the table in terms of when we are looking at different policies that make a prescription drug more affordable, right? So a number of states have taken action on, PBM reform and things like that. But I think we also acknowledge the important role that PBMs play in the supply chain. So, I think they, may play a role as a partner for PDABs if they're implementing certain policies. But then also in terms of just overall prescription drug market reform, I think all the policies, that related to PDAB or PBMs is generally on the table. So I think we just consider them an important constituent in the space, but also they have an important role to play in the space as well. So.
Yeah, great. Thank you for that. We have a number of questions around litigation, ongoing litigation, and litigation that is to come. We're not going to comment on the specifics of any litigation in this webinar, but perhaps a general question that I might pose to Ben. Litigation is not surprising. This is sort of big, significant changes in the prescription drug space. So litigation in itself is not surprising. I guess, what is your perspective on the impact of litigation and how that might challenge sort of long-term viability for PDABs?
Sure, I think it's a totally fair question. And as you sort of just pointed out, Amy, lawsuits are totally an expected outcome of any policy, no matter how big or how small, that threatens the profitability of pharmaceutical companies or anyone else in this this space. It's just a highly litigious space because there is a lot of money at stake. So again, the fact that we're going to see lawsuits, we've already seen lawsuits, and we're going to see more lawsuits inevitably, should really just be taken as sort of the status quo. That is sort of like what is expected. And it should not be construed that when a drug company or any other party files a lawsuit, shouldn't mean that PDABs are necessarily doing anything wrong, right? We have to sort of wait for the process to work itself out to really make that determination. And so that's just important to keep in mind. It's also just important to remember that what PDABs are, right? They're independent bodies appointed by state governments to serve constituents of the states. And I think that ultimately how this is going to affect PDABs is that they just have to stay focused on carrying out the statutory responsibilities that the legislatures have given them, and on, as Andy pointed out, the mission, right, which is improving affordability of prescription drugs for constituents in their state. That's what they're tasked with doing. The language will vary a little bit by state. The exact sort of tools that they have at their disposal is going to vary by state. So therefore, the specifics of the lawsuits is probably going to vary. I think the lawsuits are going to clearly take resources. The states are going to have to pay attention to them. But I wouldn't take the lawsuits to mean that this isn't working. I think that the lawsuits just are an inevitable part of any state policies around this issue.
Great, thank you for sharing that. Another question
Maybe
yeah, of course.
Add too, just real quick,
Yes.
that like the concept of states taking action to protect their consumers is well grounded in the law and in case law. I mean, and that's what we're trying to accomplish here. And so specifics that one state might run into can help guide us how we move forward. But at the end of the day, PDABs are going to be able to be effective at protecting the interests of consumers and of the state fiscal that sometimes pay too much for prescription drugs. And that core concept is well grounded.
Great, thank you for chiming in on that. Another question we have, which I can answer, and then I can been happy for you to chime in on this. So a question is, how does NASHB support states that want to stand up a PDAB? So we here at NASHB really follow the interests of states. We have an academy of all state leaders across agencies, governor's offices, legislators, Medicaid directors, HHS secretaries, social services, public health, all of those folks on our academy. And they really talk to us about, here's what we're most challenged in our states. Here's where we need your support to convene us so we can learn from one another, for technical assistance, for things that we're trying to achieve, for understanding what we can learn and how we can improve. So our work on PDABs follows the same model that we really apply across all of our work at NASHB, is really to be a support for state leaders. This is an idea and a strategy, and I think an innovator stage right now where states are trying to learn and learn from one another. So our role is really we had a model bill that really we developed based on input from state leaders. This is what they wanted to see. So there were some ideas we put together, and we share that just for pure information and education. And folks in individual states decide, okay, this is what we want to pursue. This is, we may go in a different direction on prescription drugs. We may want to, focus on health system costs. We may want to think about equity. I mean, there's all these different topics that states are going to focus on in this journey for more affordable drugs. But for our work with states, we convene, we ensure there's an exchange of best practices. States can continue to learn from one another, and we provide them with technical assistance when they ask. Ben, I don't know if you want to chime in on any of that as you.
Yeah, I think that's a great summary, Hem, and our team, sort of is a independent sort of academics group with a variety of kind of interdisciplinary expertise, and we've been really sort of privileged to work with the states on what I agree with you is sort of a innovator, cutting edge, health policy around this topic. And I mean, I think Lila and Andy can agree with this, that, the states are working with a constrained set of resources to do this type of work. And it's complicated work that requires a large amount of time and careful consideration of each specific drug and the policy at large and sort of the impact. So in addition to all the stakeholders, I think sort of bringing in outside experts and sort of learning across states, right, and sort of making sure that states are sharing best practices and sharing sort of what's been done and sort of learning from what the federal government's doing in this space around in Medicare. All of that, I think, has been able to sort of inform and move this process. And again, like keeping in mind that every state is a little different.
Oh, great. Here's one other question. We're going to try to get to as many as we can, but there are quite a few in the queue here. So one of the big concerns is that manufacturers or middlemen won't sell certain drugs in states that set a maximum price for them. Do we know what the odds are of that happening, or do we only find out after states actually try it? And I don't know if there's one of our state leaders that wants to volunteer for this one.
Yeah, I can start here. So Colorado is heading into, they've deemed one of the prescription drugs that they reviewed this year unaffordable and have, decided that they're going to begin the process to establish an upper payment limit for Emerald. And so as that process unfolds, it unfolds through the state's rulemaking process and the board's rulemaking process. But when the board was establishing the rules that guide the rulemaking process, they really outlined that they want a significant amount of information from folks. And so there's a lot of both price and cost benchmarks that they want to have in front of them to evaluate when actually deciding on an upper payment limit. And then they also specifically called out that they want to hear from providers, pharmacists, and wholesalers about what their costs are to acquire that drug. Additionally, there is time in, during rulemaking, there's testimony where we really do hope that manufacturers come and provide what their concerns are, that wholesalers come and let the board know what their concerns are. And so I think what we are hoping is for this authentic engagement to happen during the rulemaking process. So the board has full information from manufacturers, from wholesalers, from providers about what their concerns are that might lead to a withdrawal from the state. And so I think that is our hope. So not a direct answer to that question, but more of a process that we do hope for this kind of true engagement in the process so that the board can make the best decision with full information.
Yeah, no, I appreciate that. And you all are earlier in your journey, right? It's so things will develop. So thank you for sharing that. Okay, we're getting a lot of questions, but I'm going to ask a few more. So do PDABs have the legal authority to set upper price limits within a state? And so perhaps Lila, do you want to answer that, or Andy?
Yeah, I'll start and then kick it over to Andy. So in Colorado, and I know that kind of when you get into the weeds or economic terms, it gets a little redundant. It doesn't quite seem to matter which word you use, but here it does. So for us, it's an upper payment limit. So it's not the price that is set, is the payment that is made. So in Colorado, the upper payment limit applies in a number of scenarios. But it's really the amount being paid. It is not a regulation of a price that is set. It's the amount paid.
And can I ask, Lila, is that across all payers? So commercial, how does that work?
Yeah, so and we've got I'd be happy to kind of go into the weeds in some of the board's policies and things, but it applies in a number of situations. So it applies to the state regulated commercial plans. Those employer-sponsored plans could opt in to being subject to the upper payment limit. And I will note, and it also applies to individuals who are uninsured. And then I will also note that the board has called out in their policies that this would not apply to Medicare.
Okay, great. And Andy, I might have you chime in just because it operates a little bit differently in Maryland, just to make that distinction.
Yeah, I mean, I would just echo that there's definitely nothing to do with prices. This has no impact on the prices of the drug. It is simply a kind of reimbursement mechanism. And this is very common in healthcare of, things like rate setting and things like that. And then if you don't mind, I might also jump in on the last question that you just asked too,
sure.
in terms of like impact on the supply chain. I would just say that the whole purpose of a prescription drug affordability board is to increase access to these drugs for patients in the state. So it's almost the whole job of this board of experts is to make sure that risk doesn't happen, right? The whole purpose is to increase access to drugs, not reduce the access to drugs. So I think that's just something that the boards need to, be very thoughtful of and work through those issues when they're setting these policies. So I would just say that, the intention of these boards is certainly not to reduce access for any patients.
Great. Thank you for sharing that. Next question, would regulating insurance benefit design, cost sharing, be a more effective way to lower out-of-pocket costs for patients? And all of you probably have thoughts on this, but Tony, you haven't spoken up in a little bit. I don't know if you have thoughts as Minnesota's developing, thinking about limiting cost sharing versus thinking about a strategy like a PDAB.
We're pretty early in it, and a lot of people start to try to say that benefit design is the right answer for this, and benefit design is incredibly important, and I don't mean to be diminishing that, but it's one set of tools. So we're going to go back to some of the core concepts. PDAB is another tool in the toolbox. Attention to benefit design, incredibly important. The silver bullet to address a really opaque, convoluted supply chain, not sufficient. We need additional tools in the toolbox. We need that transparency, and after identifying drugs, doing a cost review, finding out what's behind the manufacturer and the drugs travel through the supply chain. An upper payment limit is something that needs to be considered. So to anyone who wants to also work on benefit design, please do, engage. Come and talk to us about how that looks for you and how you might find additional ways to engage within this space. But we're going to keep doing our work also. So it's a yes and.
Yeah.
And Hammy, I'd say just to say, like, every dollar that is spent on prescription drugs, right, is spent by consumers in some way, right? It's just important to keep that in mind. So, while out-of-pocket costs are certainly the, sort of in, for me as a physician and also a researcher, like, we know that high out-of-pocket costs are a barrier to patients accessing and affording their medicines. But we also know that high prescription drug spending leads ultimately to higher premiums and higher taxes that affect everybody in the state. And finally, like the back and forth between the negotiation of how much out-of-pocket costs, how much employers and payers and both public and private payers and PBMs on their behalf sort of set in terms of out-of-pocket costs, is directly tied to the negotiation of the prices, right? So I think it's important to think about the whole picture. And so, that's why I think we haven't seen, sort of just like flat out-of-pocket caps. We've seen this on the federal level around insulin, the $35 price cap of insulin. Very important tool. It's going to save money for people with diabetes who need insulin. It's not going to lower spending on insulin, right? And I think it's just really important to keep that in mind. The reason PDABs are a powerful tool is that they aren't just one mechanism, right? That they're thinking broadly about this topic, and maybe ultimately state legislatures might decide that out-of-pocket caps in certain areas make sense. But I think the PDABs will be able to help them sort of think through if that's ever necessary.
Yeah, and I just might comment, a number of states have taken action to impose caps on certain drugs. Like they actually, so many states capped insulin before the federal government did, right? That's one example of sort of state innovation. So I'll say from the perspective where we sit, some states are thinking about a lot of these strategies together. They're thinking about PBM reform, they're thinking about broader transparency, they're thinking about caps on certain types of prescription drugs, other ideas around benefit design, plus ideas like prescription drug affordability boards. So I think sometimes that's, it's complicated, it's hard to do, and because of we've all talked about the drug supply chain is so difficult to understand. It's important to think about and understand that states are trying to do a lot of different things all at the same time. And the states on this call in particular are states that have tried different things as well as others. So, great. So, yeah, do you want to chime in on this?
Fun question. So I wanted to jump into.
Yeah.
So I would also just echo Tony saying it's a yes and situation. So I would say like plan design, copay caps. Those are all things that are on the table, I think, when our board is looking at the affordability of a drug. But I do think that this is one of the advantages of these boards being at the state level, because this is almost the kind of conversation that the board needs to have. There's pros and cons to all these different policies and different impacts on them. So like, for example, Dr. Rowan was mentioning, if you do copay caps, then premiums go up. Like that may be a decision that one state says it's worth doing that, right? Another state may say, oh, we need to keep our premiums down. Like you get to see kind of at each state level, like if you do some sort of combination of these policies, what is the outcome of that? Like right now, another example is one thing that's very common in the drug pricing space is basically these like highly rebated drugs are functionally subsidizing premiums for everyone else, right? So you have like the sickest patients basically subsidizing premiums for the healthiest patients. Like that's how it works now. Like maybe that's the right way it should work, but that's like a conversation that these boards should have. And they're complicated and difficult conversations, but this is the kind of right group of people to kind of think through and talk about those issues.
Yeah, I appreciate that. And if those of you on the line are interested in understanding all the different types of state legislative strategies, we have a tracker on our NASHB website that has all the different things that states are doing with drug pricing. So we can put that in the chat. Okay. This question, I'm not sure who wants to take it. Will consumers in a state with a PDAB experience cost savings as a result of PDAB work? So I don't know who wants to take that.
I can start just because of how it's going to work differently for different states. So one of the conversations our board's been having is, so upper payment limits in Maryland are for state and local government. So you can picture Medicaid, also state employee health plans, direct purchases by the states and things like that. Our board very early on said they want to prioritize making sure that any savings that comes from an upper payment limit, that the patient gets some benefit from those savings. But the issue that we actually ran into in the state is Medicaid has a nominal fee for their patient population, right? It's like a $1 copay basically. So there's no way that we're going to probably reduce the copay if we do anything with Medicaid. And then same thing for our employee health plan. It's actually like a copay based structure, right? So it's like there's a flat fee. So there's actually limited work that we can do. So it's almost that all of our savings goes straight into state coffers, which is like good for the state as a whole. It will certainly benefit the patients that are on these plans. And then also it helps our general taxpayers. As soon as you get to the full market, then you have kind of broader implications where if there's plans that are kind of co-insurance based, which means that it's often like some sort of percentage of an amount that the insurer says they're paying for the drug, then all of a sudden there's opportunity that goes more towards the patient. So I would just say it kind of differs by state and exactly how the upper payment limits are implemented.
Yeah.
Yeah, and I would just add to that, Colorado, our law specifically calls out that carriers, if there's any savings from an upper payment limit, that savings must be passed on to consumers, either in the form of reduced out-of-pocket costs or reduced premiums. And we even have a sample Excel template that we've created for carriers so that they can demonstrate kind of what any savings from a UPL, how that was passed on to consumers. And then also noting too that the out-of-pocket costs for consumers differs if the medication is physician administered versus a pharmacy, a prescription you go pick up at the pharmacy. And so we were lucky to have expertise from the 2 pharmacists on our board and the 3 physicians, really providing that perspective of just the different settings in which consumers access these drugs.
Great. And you almost anticipated my next question, Lila, because the question was, how are board members appointed, and do states anticipate including pharmacists on these boards? So you've answered the second question. You have pharmacists on your board, but maybe perhaps the 3 states, you can just talk a little bit how your board members are appointed. Lila, you can go first, and then we'll go.
Yeah, I'll start it off. So our 5 board members are appointed by the governor, by our Governor Polis this round, but the governor appointed positions. And then they need to be confirmed by the Senate in Colorado. And so we had, I was actually not on board when the applications went out and the appointing was done. We had a large pool of very qualified candidates. And so really looking at gathering, I think there was importance on diverse perspectives in terms of geography, race, and ethnicity of board members, as well as kind of that pharmacist versus physician versus critical access hospital, federally qualified health center, and large hospital setting.
Great, thanks. Tony?
Minnesota, we have 7 voting members appointed by the governor. We have a representative from the House of Representatives and one from the Senate as well. They're non-voting members. The 7 governors appointees, there's not much it's not much prescribed. We have 3 researchers from the University of Minnesota, pretty much. We have 3 from specific disease communities, pretty much. And then me, an old policymaker from rural as well, with a little bit of geographic balance. It's been a good functioning board so far. We need we need to get an executive director. We need an Andrew and a Lila. We're on the path.
Great. So if anyone's interested in helping Minnesota, there is an opening for an executive director. Go find him. Andrew.
And one other piece to make about the boards too, and I think this is the case with all of these boards. We're all volunteer boards who have just a passion and a lived experience that gave us some real insights into how important this topic is, and to people, to real people. And so we're here, because we care, and volunteering our time. Again, that's why we got to get some of the paid staff in that can,
No, thank you for sharing that. You all have full-time jobs doing different things, pharmacists, clinicians, hospital administrators, other folks, and you're volunteering your time to do this work. So thank you. Andrew, Maryland.
And I'll just very quickly add, just because this is one of the areas where the states can kind of differ. So Maryland is an independent agency. We're not housed in any other agency, which kind of makes us unique. And then also our appointment structure is pretty unique. As you heard, a lot of the other ones all kind of are governor appointments. Ours has our chair is appointed by the Speaker of the House and the President of the Senate. Then the Speaker and President each get their own appointee. And then the AG's office gets an appointee, and then the governor's office gets an appointee. So just again, kind of a unique structure, but that's also kind of one of the innovations that states can do is kind of differences in that space. And I also just echo Tony's point, the service and sacrifice that our board members have made is significant. So it's a true labor of love, and they put a lot of work in. So
thanks for sharing that. Okay, I think we're getting probably towards the end. There is another question specifically for Lila in Colorado. So the question is, Colorado has made progress with drug importation. How does this effort intersect with the PDABs work?
Yeah, absolutely. So I believe we speak with our sister agency, the Colorado Department of Healthcare Policy and Financing. It's our state Medicaid agency frequently. And so we're in contact with them frequently, particularly the Canadian Drug Importation Program. I believe the current status is they've answered a number of questions from the federal government about, before the federal government might potentially approve their plan. And I believe they're still waiting to hear on final approval. But that agency did release a list of prescription drugs that would be eligible for importation. And so when the list of drugs that were eligible for potentially selection for affordability reviews were released, we did compare those and look at them to see. And I will say there is some overlap between the prescription drugs, but not as much as we might have thought. I think it has to do with the criteria really on the drugs that could be imported from Canada versus the drugs that kind of rise to the top of our board's list when our board was deciding what they wanted to focus on. But we are in conversation, should that happen, that the board kind of conducts an affordability review of a drug that is on that list, the Canadian importation list, and what that might look like, and how that might intersect if the board were to deem that drug unaffordable and want to go through the rulemaking process to establish an upper payment.
Great. Thank you for sharing that. Okay, so in the last 5 minutes, we'll do a lightning round, and I'll just ask one question for all of you. What do you see on the horizon for PDABs in the year ahead? Challenges, opportunities, lessons learned, anything that you want to share with the folks on this webinar? I'll start with Ben.
Sure. So I mean, I think on the horizon, I mean, I'm excited to see the implementation of upper payment limits, or this new policy in several states over the next year or two. And I'm excited to see how other states that are sort of watching this process learn from what the PDABs that are existing are doing and implement sort of new legislation, new processes that sort of build upon the success and sort of learn from sort of the challenges that the boards have faced. That's what I'm sort of looking forward to.
Great. Lila?
Yeah, I'd say so. Similarly, the process of upper payment limits and that rulemaking process. And then I think another thing that we're excited about that we see as kind of an opportunity and a lesson learned is we really learned over the past year that when you're working with patients, particularly very small patient groups, right? It is somebody with the condition, it is their child has the condition, and they don't typically engage in the regulatory space. You know, they don't typically monitor what's happening in the state space, where they might, but not in this way. Really identifying and learning from how we engaged with them last year and how we could better engage with them earlier on, and really just be a space where they can come and ask us questions, so that really to help explain the process, to kind of ensure that the fear that comes with the unknown when you don't understand a regulatory process or you don't know what's going to happen, creating that space where we can work with those groups early and often, to make sure that they understand what is the potential, and how they can engage.
That's great. Tony?
You know, I'm going to echo Lila's community engagement, really, you know, trying to make sure that we have an open, transparent process to hear from consumers and from industry. I personally, I'm sort of a data geek. I'm really anxious to start having some of our supporting agencies help us put some of these data sources together and overlap them and really try to unpack and get at what's going on here, so that we can make good decisions. And we have an incredibly engaged legislature and governor too, that you know, through that engagement, you know, if we need to make some changes, they've signaled the willingness to work with us to have some legislative changes as well. So community engagement, fact finding, data, and adjusting as needed. A lot of work to do.
Yeah.
Fun though.
Good. I'm glad you think it's fun. Let that continue. Andrew.
Great. Yeah, I was nodding when Dr. Rome mentioned implementation. I wouldn't necessarily limit it to upper payment limits. I would say just overall, our work has had a very long runway. I mentioned that our board was created in 2019. And we are just now at the point we were actually kind of doing the work, whether they be the cost reviews or other policies that are implementing. So I just think hopefully within the very foreseeable future, patients will be able to actually kind of feel the work that we're doing. It'll go from talk to actual action, and we're very excited about that. And in terms of lessons learned, I think there'll be a lot of lessons learned as we get to that step, right? Each state will kind of approach it in their own way, and I think folks will be able to learn from each other on how that works.
Great. Well, I just want to say thank you to all of you for your time today, for your efforts and your work. And thank you to the audience for joining us. I hope you learned something new and got some insights on the states and what they're really trying to do with their PDABs. We are going to follow up with the recording of this briefing as well as the resources shared in the chat. So please don't hesitate to reach out to the email in the chat if NASHB can be a resource to any of you. Have a wonderful afternoon. It's very hot here in DC, so wherever you are, stay cool and enjoy the rest of your day. Thanks all. Take care. Bye, everybody.